Welcome and good morning, everybody. Thank you so much for joining us today. My name is Alex Peters, and I'm an outreach specialist with the Wisconsin Comprehensive Cancer Control Program. We staff and facilitate the Wisconsin Cancer Council, our state's diverse cancer control coalition. Our goal with these calls is to share interesting, relevant information that you can hopefully take back to your own work. And more importantly, leave time on each call for discussion and conversation with the presenters, the Wisconsin CCC team, and your fellow council members. The format will be the same for all of these calls, but the topics will change. We'll use half of the call to share information and the second half for dialogue. We can accomplish so much more by working together, and that's the ultimate goal of the Wisconsin Cancer Council. Feel free to use the chat box for questions throughout today's presentation. This month's topic is medical marijuana in Wisconsin, a cancer perspective, presented by our very own Amy Johnson, policy coordinator for our program. Before Amy gets started today, I will go over today's agenda, starting with some exciting news and updates.
Enter your participant ID followed by pound. Otherwise, just press pound to continue.
All right. So we have an exciting and busy 2020 plan. Save the date because regional meetings will return this spring. The Wisconsin CCC team will soon be coming to a city near you, and we hope you can join us. Registration for these regional meetings will open in March. Additionally, save the date for our annual Wisconsin Cancer Summit happening this October on Wednesday, October 28th and Thursday, October 29th at the Edgewater Hotel in Madison. We hope we see you at a regional event as well as our annual summit. With that, I am happy to hand this over to our policy coordinator, Amy. Thank you.
Good morning. I'm Amy Johnson. I'm the policy coordinator for the Wisconsin Comprehensive Cancer Control Program. Today we'll be discussing, moving on to the next slide. There we go. Today we'll be discussing medical marijuana, what it is, what's the research, health and policy considerations, pending legislation, and we'll wrap up with time to answer your questions. I need to state for the record that the Wisconsin Comprehensive Cancer Control Program serves as an educational resource only. We do not advocate for or against policy issues and have not adopted a position on this issue. Okay, let's dive in. As you may know, there's been interest in legalizing marijuana for medicinal use in Wisconsin for the last few years. However, the effort really took off last year with the governor's budget proposal, and since then a few bills have been introduced in the state legislature that would legalize it. When advocates speak of legalization, they almost always mention that people living with cancer would benefit. We decided to unpack that and approach the topic of medical marijuana from a cancer perspective. You can read about this in our newly released issue brief. I'll be working my way through the issue brief, but I won't follow it in order of the pages in case you want to follow along that way. Yep. So starting off with the definition. When we say medical marijuana, we mean the use of the whole unprocessed cannabis plant or its basic extracts for therapeutic purposes. Cannabis plants contain more than 100 chemical compounds called cannabinoids. The two most commonly known are delta-9 tetrahydrocannabinol, the one commonly referred to as THC, and the other, cannabidiol, which is known as CBD. For your reference, THC is the agent responsible for producing the sensation of being high. To date, 33 states, the District of Columbia, and 3 U.S. territories have legalized medicinal use of marijuana for their residents through the legislative or ballot process. These jurisdictions have developed a list of health conditions that they believe would be useful in addressing the symptoms and side effects of. First of all, how are we doing on audio? Has it improved? Okay, all right. Continuing on, nearly all states have identified cancer, mainly pain or symptoms from cancer treatments, as a health condition that qualifies a patient to use marijuana legally. In the 2019 analysis of patient-reported data, cancer was the third most commonly cited medical reason for using marijuana after chronic pain and multiple sclerosis. Cancer patients reported using marijuana to ease nausea, vomiting, and pain related to their disease, as well as other cancer symptoms and side effects from treatment. Most states require patients to obtain proof of their qualifying medical condition from a licensed medical practitioner. This practitioner must certify that therapeutic marijuana use would likely outweigh the potential risks to the patient. Practitioners do not write prescriptions, but rather they typically complete a certification that states that a patient may use medical marijuana. So why a certification, not a prescription per se? It's illegal for physicians to prescribe marijuana because it's a Schedule I drug, and prescribing it would constitute aiding and abetting the acquisition of marijuana, which could result in revocation of DEA licensure and even prison time. They're allowed to discuss medical marijuana with patients thanks to a lawsuit that determined it was a First Amendment issue. Okay, so let's go back to the point at which a patient is certified by their medical practitioner. A patient applies to a state registry that tracks them and typically receives an ID card, which they bring with them to a medical marijuana dispensary to purchase the drug. How medical marijuana is consumed can vary widely. In general, marijuana can be consumed by smoking, vaporizing, eating products infused with cannabis extract, known as edibles, or in other forms such as pills and oils. Presently, 3 states and Puerto Rico prohibit smoking the drug and instead require that it be vaporized or consumed as an edible product. Conversely, 7 states ban or limit the sale of edibles because of concern they may resemble foods appealing to children. We did briefly cover CBD in the issue brief. Cannabidiol is a hemp and cannabis-derived compound that contains no or very little amounts of THC. Essentially, it cannot exceed 0.3% THC.
Okay, thank you.
Oh, we're having trouble with, folks, if you could mute your phone line. Okay. So it can't, CBD cannot exceed 0.3% THC and therefore doesn't produce the sensation of being high. While you can find CBD products in many places and contained in many products, as you probably know, CBD products have not been approved or evaluated for safety by the FDA. There is one FDA-approved drug containing CBD, which is a prescription medicine used to treat certain seizure disorders. Okay, this is a map of the current 33 states, District of Columbia, and 3 territories with some form of legalized access to marijuana. The dark blue states have legalized recreational and medicinal use. The light blue states are medicinal use only. The states in white, such as Wisconsin, have legalized neither. As you can probably tell, our neighbors here in Michigan and Illinois first legalized marijuana for medicinal use and are now on recreational use as well. Marijuana's current legal status dates back to the passage of the Controlled Substances Act in 1970. The law created 5 schedules. Marijuana is illegal under federal law and is classified by the Federal Drug Enforcement Agency, the DEA, as Schedule I drug, the highest possible restriction level. Schedule I drugs are considered to have a high potential of abuse without currently accepted medical use and lacking safety for use under medical supervision. Here in Wisconsin, THC is classified as a Schedule I drug as well, but under the Wisconsin Uniform Controlled Substances Act. Therefore, it's illegal to possess, sell, and manufacture marijuana under state law. So understanding the laws in place helps in turn to understand the challenges to researching marijuana for therapeutic purposes. Here's the problem. Marijuana is Schedule I and has no currently accepted medical use in treatment because there's insufficient data on its safety and efficacy. There is insufficient data because marijuana is Schedule I and clinical testing is restricted, kind of a circle there. To give you a sense of the barriers to research, investigators seeking to conduct research on marijuana must navigate a complex process that may involve the National Institute of Drug Abuse, the Food and Drug Administration, the DEA, institutional review boards, agencies and state government, state boards of medical examiners, the researchers' home institutions, and potential funders. So obtaining the marijuana for research is complicated in itself. The only source is through the University of Mississippi and authorized by NIDA. Other facilities have been permitted, but the university holds the monopoly to date. But the focus of NIDA is the cause of drug abuse and addiction instead of looking at therapeutic uses of marijuana. So as a result, less than 1/5 of the cannabinoid research funded by NIDA concerns marijuana's therapeutic properties. And that 1/5 is spread out under many conditions, not just cancer. About the marijuana, researchers can designate the level of THC, basically its potency, up to about 10%. However, this does not match what's available in medical marijuana dispensaries. Using a non-work device, I decided to look at the marijuana website of a dispensary in Illinois that provides marijuana. Surprising to me, the lowest THC level for combustible marijuana was 17%. The average was the upper 20s and into the 30s. Concentrates and edibles were another story. Edibles range from 5% THC to upwards of 100% THC. The average THC level for concentrates was 71%, so far different from the 10% that's being studied. Another fact about the marijuana, the studies that are conducted primarily use marijuana that's in combustible form. Edibles have not been studied, and there's sparse research on vaping marijuana for therapeutic purposes. Those of us in cancer prevention and control would typically discourage the use of vaping or combustibles. An additional challenge with studies using combustible marijuana is the method used by the participant. Not all participants will be comfortable inhaling marijuana smoke, and they will not inhale it consistently with other patients. These barriers lead many researchers to conduct observational studies in which they interview and track patients who use marijuana during cancer treatments. The researchers were not supplying or administering the marijuana. From the studies I reviewed, most interviewers did not report how their participants obtained the drug, the form of marijuana, or did they track how much THC was contained in the drug used. In some cases, users don't know how much THC is in the product. There we go. Turning now to the negative health effects of marijuana use. Researchers have determined that average marijuana smokers, or those that smoke an average of 1 joint per day, inhale more deeply into their lungs and hold their breath longer than tobacco cigarette smokers. As a result, average marijuana smokers typically inhale 4 times more tar and therefore more carcinogens than tobacco cigarette smokers. Regular marijuana smoking has been found to cause visible microscopic changes to the lungs, consistent with the changes seen in tobacco smokers diagnosed with chronic bronchitis. These changes are consistent with the increased incidence among marijuana smokers for developing symptoms of chronic bronchitis. When the incidence of these symptoms were compared to regular tobacco users, marijuana smokers had similar rates of coughing and wheezing. However, evidence from studies of light and moderate marijuana smoking does not suggest an increased risk of upper airway and lung cancer, but the evidence is mixed for heavy long-term marijuana smoking. Another recent study suggests that people who smoke marijuana may be more likely to later smoke cigarettes. This association, of course, is significant as cigarette use is linked to 80 to 90% of all lung cancer deaths. Presently, no widespread scientific evidence exists regarding the health effects of marijuana consumed in non-combustible forms, such as edibles. So given the limited evidence available, further research is needed to determine whether it is the combustible nature of smoking marijuana or the drug itself that produces the health issues. In 2017, the National Academies of Sciences, Engineering, and Medicine conducted an exhaustive review of studies on health effects of marijuana and reached the following conclusions. There's insufficient evidence, meaning a conclusion cannot be reached, to suggest smoking marijuana increases the risk of prostate cancer, cervical cancer, malignant glioma, non-Hodgkin lymphoma, penile cancer, anal cancer, Kaposi sarcoma, bladder cancer, or esophageal cancer. There is limited evidence to suggest smoking marijuana increases the risks of one subtype of testicular tumor. A conclusion can be made, but there is significant uncertainty in the findings of the studies. Continuing on, there's moderate evidence from several findings from good to fair quality studies that smoking marijuana does not increase the risk for lung or head and neck cancers. Researchers have been unable to link light and moderate use of marijuana smoking to increased risk for lung or upper airway cancer. However, there's conclusive evidence, meaning that a firm conclusion can be made, that oral cannabinoids are effective in the treatment of chemotherapy-induced nausea and vomiting. This relates to the research performed by the FDA-approved drugs, Drobenol, which is a synthetic THC, and Nabilon, which are second-line treatments in nausea and vomiting induced by cancer chemotherapies. In addition to the findings from the academies, we also cover findings from Minnesota's medical cannabis program's survey of patients with cancer during their first 4 months of program participation. Minnesota's program is unique in that patients report their experience using marijuana in treatment for their conditions. The state had cancer patients report about changes in anxiety, lack of appetite, depression, disturbed sleep, fatigue, nausea, pain, and vomiting. A significant reduction in scores across all symptoms was found in patients within their first 4 months of program participation. This does not account for participants who dropped out of the program and as a result stopped reporting. It only comes from the patients that continue to use marijuana for their cancer symptoms. As I covered earlier, a patient's first step to being added to the state's registry and obtaining marijuana is a visit to a medical doctor or a physician assistant or an advanced practice nurse prescriber. States typically require that a medical practitioner has a bona fide relationship with their patient, meaning the professional is fully informed of the patient's health condition and has been treating the patient for a set amount of time before certifying. Some states require the medical practitioner to explain the potential risks and benefits of using marijuana for medicinal purposes. Here's the challenge. Unlike prescribing medicines or other treatments that come with exhaustive research and findings, there isn't close to being a similar amount of information. Also, unlike pills or other treatments, there are forms like edibles that haven't been tested and may have different dosing than combustible forms. Patients may receive guidance from bud tenders at the dispensaries, but the bud tenders, of course, do not have medical training anywhere near on par with a medical practitioner. Furthermore, unlike prescription meds and treatments, the marijuana and its growing and cultivation are largely unregulated and unstandardized. This leads to safety concerns by practitioners. This gap in available research has significant implications for patients and providers. For example, a Dana-Farber Cancer Institute survey of 237 oncologists nationwide found a concerning discrepancy. 80% of the respondents reported talking with patients about medical marijuana. 67% believed medical marijuana was a helpful supplement to standard treatment. 46% had recommended the use of medical marijuana in the past year. Yet only 30% felt sufficiently informed to make specific recommendations for use and dosing. Comments from the oncologist indicated concerns about lack of clinician knowledge, drug efficacy, side effects, and drug interactions. The majority of states have moved forward with medical marijuana legalization despite a lack of conclusive scientific evidence of therapeutic benefit. Before medical marijuana becomes legal in Wisconsin, we recommend that public health leaders and policymakers examine a number of considerations to mitigate any negative or unintended impact such a law might have. These considerations include, but are not limited to, a health impact assessment that identifies how legalization of medical marijuana might adversely affect the health and safety of Wisconsinites, as well as strategies to mitigate potential negative health outcomes. The state of Vermont and the state of Kansas have both conducted health impact assessments on marijuana regulation. The assessments, which analyze a broad scope of factors associated with marijuana legalization, may serve as models for Wisconsin public health officials. For your reference, Vermont has legalized medical and recreational marijuana, while Kansas has neither. If you're interested in more information, to find the health impact assessment for Vermont, just search by marijuana regulation in Vermont. The health impact assessment for Kansas was produced by the Kansas Health Institute. Another consideration is having education for healthcare providers and healthcare systems so that providers understand the risks and benefits associated with medical marijuana use, and health systems are equipped to provide adequate guidance to staff in treating patients. Also consider the dangers of impaired driving for people who consume medical marijuana. Research shows that the odds of vehicular accidents, crash culpability, and fatality increase with blood THC levels. A blood THC concentration of 5 nanograms per milliliter increased the odds of crash responsibilities to levels similar to that of a blood alcohol content of 0.15. And finally, potential revisions to the state indoor smoking laws, which currently apply to only combustible tobacco products. Looking at policy considerations, at the heart of the matter, we just don't have enough information to know the therapeutic effects of marijuana because it's a Schedule I drug. Reclassifying marijuana away from a Schedule I would loosen the restrictions on research findings and could resolve questions surrounding the drug's health effects. However, drug reclassification only occurs by an act of Congress or through an administrative review process approved by the U.S. Attorney General or the Secretary of the Department of Health and Human Services. In Wisconsin, efforts to legalize medical marijuana at the state level would present challenges to existing state policies. As I mentioned previously, THC is classified as a Schedule I drug under the Wisconsin Uniform Controlled Substances Act. Residents of Wisconsin who consume marijuana and test positive for THC may also lose eligibility for certain state and federal assistance programs. Legislation on the state level to legalize medical marijuana should address this conflict with existing laws. Lawmakers may also want to consider the conflict between an employer's practice of employee drug testing and a patient's legal use of medical marijuana. Fewer than half of the states that have legalized have attempted to resolve the problem by enacting employment protections for patients. And I'm going to go through quickly this list here. So in addition to any legislative initiatives to legalize medical marijuana in Wisconsin, it should include a list of all qualifying medical conditions necessary for patients to obtain and consume medical marijuana. It should create a registry for qualified patients to obtain it, including the time length in such a registry, and establish a process to license caregivers who wish to obtain marijuana for qualified patients. It should regulate the operation of dispensaries and producers, develop consistent and accurate label of products. It should establish routine lab testing of products for potency and ingredients, set dosing guidelines and quantities of the drug available for possession by patients, determine restrictions and penalties for those who violate the law, designate state agencies with oversight authority of growers, processors, dispensaries, and patients, and finally, consider public health implications such as impact on impaired driving laws. At this time, there are no established policy guidelines that would allow states to more uniformly follow best practices when enacting medical marijuana legislation, which of course leads to inconsistencies among various state laws and programs. However, almost all states have legalized it to allow patients who have been diagnosed with cancer, who are undergoing cancer treatments, to access medical marijuana with their medical professional certification. I should also note that a number of the states that have gone through the marijuana legalization continue to enact revisions to the laws. A lot of them continue to add more conditions to laws as time goes on. So just because you pass it one time doesn't mean it's set and done. Okay, let's look at the legislation that's been introduced in Wisconsin. There are 3 bills. First of all, there's Assembly Bill 220, Senate Bill 377. This bill also legalizes recreational marijuana. But looking at the medical marijuana provisions alone, the bill would require a patient to see their physician to obtain a written certification, which says the physician believes the person's use of THC would likely outweigh the health risks. A patient would be required to pay a registration fee of $150 and receive an ID card valid for 4 years. It covers 12 medical conditions, including cancer, plus chronic diseases that cause severe pain, severe nausea, seizures, etc. Considering this bill introduces both recreational and medical, you might ask why a person would go through the certification process for medical marijuana. Under this bill, the marijuana would be covered under some insurance plans as a prescription. Plus, taxes on recreational marijuana would be substantially different than medical. A person would be limited to having no more than 6 live plants and 3 ounces of usable marijuana. You probably see a lot of 5s, 7s, and 0s, and I've checked these numbers 3 times to make sure their numbers are correct. But turning to Assembly Bill 570 and Senate Bill 507, this is the first strictly medical marijuana bill to be introduced, and it's also the most bipartisan. This bill and the first bill I mentioned would place the responsibility of the registry under the direction of the Department of Health Services. A person would obtain a written certification from their physician, physician assistant, or advanced practice nurse prescriber. They'd pay a registration fee of $150 unless they're on SSDI, SSI, or have veteran status, and that fee would be $50. The bill lists 10 qualifying medical conditions, including cancer, and other conditions that cause severe pain, severe nausea, seizures, etc. The Department of Ag, Trade, and Consumer Protection, known as DATCP, would be responsible for the condition and testing of the product, as well as regulate producers, processors, and dispensaries. In this bill, a person would be restricted to no more than 12 live plants and 3 ounces of leaves or flowers. The third bill, Assembly Bill 750, Senate Bill 683, was intended to address concerns raised by leadership in the Assembly and Senate. The bill takes a different approach to the regulatory structure because it creates a medical marijuana regulatory commission under the Department of Revenue. Like the second bill, a person would obtain a written certification from their physician, physician assistant, or advanced practice nurse practitioner, prescriber rather. The bill lists 8 specific qualifying medical conditions, including cancer, but it allows the commission to add to this list. A person would be required to pay a registration fee, but that will be set by the commission. Also, the marijuana will be in the form of a liquid, oil, pill, or tincture, or in a form that is applied topically. So where do things stand with the bills? Well, both the Speaker of the Assembly and the Majority Leader of the State Senate have stated that there is not sufficient support to move the bills or hold hearings. Speaker Voss has expressed support for a limited medical marijuana program, while Majority Leader Fitzgerald has voiced his opposition in that of his caucus. Any activity on medical marijuana legalization will simply have to wait till next year. Okay, to wrap up, cancer and its treatment can be debilitating, and current therapies to address symptoms and side effects are not always effective. Patients undergoing cancer treatments deserve access to therapies that safely and effectively reduce the physical and psychological toll of their disease. Increasing patient access to care, including effective symptom management, is a priority specifically identified by the Wisconsin Comprehensive Cancer Control Plan 2015 to 2020. Observational studies suggest marijuana may be an effective therapy for some patients, but because of federal barriers limiting research of marijuana, the medical community simply does not have the scientific evidence to support these claims. In this environment, patients, providers, and policymakers who wish to assess the drug's therapeutic efficacy are forced to rely on limited, often anecdotal evidence. Any legislative proposal to legalize medical marijuana should take seriously this critical gap in available data. The use of medical marijuana may present benefits to some patients while producing unintended health and safety consequences for patients and the public at large. Okay, now we have some time for your questions. You can unmute your line, or you could enter it in the chat box. Thank you, Melissa. Just while we're waiting for more questions, the issue brief was released on Monday and is on our website. So if you'd like to read more about it, please do. And Carrie just posted a link to the issue brief. Thank you, Carrie. So Dr. LeConte asked the question, if we were able to do large clinical trials of marijuana, who would fund this? And the NIH is their FDA process to make that happen. The process is quite complicated, and I can follow up with more information, but I'm not entirely sure where the funding source would come from, to be honest with you. We just know there is some funding from NIDA, but some of this takes place privately, I imagine. Yes, it is being recorded, and the PowerPoint is being recorded.
It will be sent out in a follow-up email shortly after.
Sherry's question, if we know that Wisconsin health systems or health insurance companies are taking a position on this, I might turn this over to see if H.J. Waka is on the line. I haven't looked to see where the lobbyists have registered in their support or concerns about the bill. So I'm not sure offhand where the insurance companies are on this. And it may be one of those things that, knowing that the bills just are not going to have a hearing, they may not put the effort right now into lobbying on it. They're definitely probably watching it. Allison Antoine asked if medical marijuana research is happening in other countries to help fill the research void that we currently have. There is research that is being done in other countries that don't have the restricted levels that we do. Some of that is still developing. So that's, there was one recent study that a product called Sativex had been studied, but it was not producing the results that it wasn't shown to reduce cancer pain in patients. And Mari, you know someone in the office you can find out who will, yeah, you could follow up with me. Yeah, let me type my email here. There's my email address. There are a few Amy Johnsons in the world, as you can see. Any additional questions? We'll wait just a few minutes for folks to type in if they'd like. And you can also follow up with me. I listed my email address there. If you have questions that you'd rather ask that way, feel free to do so.
Well, thank you, Amy, so much for that great presentation. And looking ahead, we do have some upcoming webinars we'd also love you to have join. Coming up on March 12th, we're going to share some information about the Wisconsin Cancer Summit, as well as some really exciting updates. April 9th will be a webinar discussing the connection between cancer risk and alcohol use. And then finally, in May, we will not be having a monthly webinar. Instead, we strongly encourage you to attend one of our regional meetings. Thank you all again for joining today. The slides will be sent out via email, as well as a copy of the PowerPoint. Thank you all and have a great day.